Today we are going to discuss about Conn's syndrome. So what is Conn's syndrome? It is basically hyperaldosteronism, right? Hyperaldosteronism with suppressed plasma renin activity. So this aldosterone secretion is related to angiotensin 1 and angiotensin 2 along with renin activity, right? So what is the cause of hyperaldosteronism? First, aldosterone production is from zona glomerulosa. Yesterday we had talked about glomerulosa. So yesterday we had talked about Cushing's. Now we are talking about this Conn syndrome. So which are essential to know about adrenal carcinoma. Okay, like adrenocortical adenoma mainly. Okay. So along with the plasma renin activity, there will be suppression of the renin activity. What are the causes for this? In first cause is any tumor, primary adrenocortical adenoma in 60% of cases, and next idiopathic. If you don't know anything the cause, we'll write idiopathic, right? In 30% of cases. Okay, so what is the aldosterone function? You tell me. Aldosterone will help in potassium retention or potassium excretion. So K plus excretion it will help. So right, and it will also help in sodium and water reabsorption from DCT. So what will happen in this? This is increasing, right? So excretion will also increase, urinary potassium excretion increase, absorption of sodium and water increases. So this may leads to hypernatremia. This leads to hypokalemia. So the patient who is coming with primary hypertension and hypernatremia and hypokalemia, it is difficult to control in this case. Okay, and hypokalemia, this case is difficult to manage, and you should be seeing the ratio of plasma aldosterone concentration to plasma renin concentration, which will be greater than 30, because plasma renin concentration is decreasing and plasma aldosterone is increasing. So the ratio will be greater than 30 here. Okay, and what investigations you will do? You will do investigations CECT, contrast enhancing CT scan. So to rule out any adrenocortical adenoma, and you also do one gold standard test is there, adrenal venous sampling, and you will also do urinary potassium levels entundi levels, and also you will do electrolytes how they are present. And in this case there will be in electrolytes potassium decrease, sodium increase, and there will be metabolic alkalosis. Alkalosis will be there, right? This is about Conn syndrome. We had forgotten one thing, that is treatment part. So in this the treatment is, in case of any tumor, we will do adrenalectomy, unilateral adrenalectomy or bilateral based on the condition you will do. And medical management in case of idiopathic causes, you will do you will give spironolactone to patient, which is potassium sparing diuretic. That's it guys, today the second part of adrenal gland, which is Conn syndrome, right? And let's discuss about another thing in the same video. This is virilizing syndrome. Virilizing syndrome or adrenogenital syndrome, right? So we had read that we have three zones. One is zona glomerulosa, just before we had discussed, and zona fasciculata, another thing. Now we are left with one more zone, which is zona reticularis. We had already taught that zona reticularis will produce sex steroids in our first adrenal gland topic. So these sex steroids mainly DHEA. So this may be idiopathic like that. So congenital adrenal hyperplasia is also one cause. So in females, the clinical features will be the virilism, ambiguous genitalia, mons pubis. This is labia majora. This is labia minora. You'll have clitoris here, and you will have hymen and vagina. So this clitoromegaly will occur in case of adrenogenital syndrome. And in males, you will see precocious puberty, and epiphyseal fusion, early epiphyseal fusion, which leads to stunting of growth and short stature. So and what is another thing is congenital adrenal hyperplasia due to 21 hydroxylase enzyme deficiency. So it is actually usual, no treatment as such for congenital adrenal hyperplasia except in females. In females, you will treat if there is any hyperandrogenism, androgen excess if it is there, you will go with the treatment. Okay, and if it is autosomal recessive, you will you will replace the deficient steroids. Okay, you will give deficient steroids. And in case of in females, if there is any androgens are increased, then you will go with surgery of the gland. Okay. That's it guys, today we had discussed two syndromes. One is Conn's and another one is adrenogenital syndrome or realizing syndrome. Thank you guys, thank you.